There we go, Andrew.
Okay.
Sorry about that.
All right, so after much fiddling around with technology, welcome to all of you to this presentation. We're going to talk about fetal lactate estimations in labour. Now, my main objective here is that, first of all, clearly we'll focus on scalp lactate estimations in labour. And the objective is that just to convey some understanding about its current role, use and effectiveness and where it might be heading. So just the next slide. The background to this is that there's a lot of interest in about fetal welfare in labour. When a woman goes into labour, we want to know whether that baby is coping with contractions, and I'm saying the obvious. Now, our main tool for that, apart from clinical estimations, which are just so important, intermittent auscultation, but if we want to do it in a more concentrated way, then it's CTGs in labour. Currently, there are no good alternatives to CTGs. There is this thing called ST analysis, but in fact, it doesn't seem to be that much better than a CTG. Now, the issue around CTGs, which I'll expand on, is clearly that they have limitations. They are a very limited screening test, which generally overcalls the situations. Too often it tells us that a baby might be in trouble when in fact the baby is not. When a baby is really in trouble, sometimes it gets it, most of the time it gets it, but it's not that clear always.
Andrew, do you want me to move to the next? Do you want me to move to the next
I'll
slide?
let you know. No, yeah.
Okay.
So that's just one issue. The next thing is that we've got rising caesarean section rates, and these are literally going out of control. There is a lot of interference in labour so that our rates of normal birth are going down, and a lot of this is because of CTGs. What's further fueling this, and is very relevant to our topic, is the medico-legal anxieties around birth. Now, this is very significant because every discussion you have about birth, there's always some final reference to, and how will this stack up in court? Now, I don't think that's a very good thing, but that's the reality, right? So can I just have the next slide, thanks? So the role of CTGs, first of all, CTGs are designed to pick up, to give us an idea that a baby might be hypoxic. I don't think we should use the word fetal distress. It's we're the ones who get distressed. Babies get a bit hypoxic, and that's what we're trying to pick up. The limitations, and so just remember, CTGs are being increasingly used because of the increasing number of inductions that we're doing and our ability to define risk factors. It is a screening tool. However, it has limitations, significant limitations. It has a very high false positive rate, and even the most abnormal CTG, there are varying false positive rates of 60% right up to 90%. You'll get a lot of debate about that, but everyone agrees that it overcalls it. To what extent, will be the subject of debate, but it's substantial. Fortunately, it does have a low false negative rate, but you should remember that it can happen. I've seen it where everyone's thought that a CTG is quite normal and a baby has come out terrible. But fortunately, that's not very often. And most of the time when a CTG is normal, we know quite confidently that a baby's okay. The problem with CTGs, a central problem, is the whole problem with inter-observer variation and intra-observer, sorry, that should be inter-observer consistency and intra-observer consistency. And you get 10 people in a room, even experts looking at the one CTGs, you can easily get 10 or more opinions about that CTG. The other thing is the same person looking at the same CTG can also vary, and this is a major problem. And remember, the other thing is that CTGs dominate medico-legal cases. So while we can have these exasperating concerns about their effectiveness and limitations, we do need them. So, next slide. In order to deal with that, previously we used to use Scalp PH. We would get an abnormal CTG, and if it was sufficiently abnormal, we'd take at least 30 microlitres of blood or a bit more, and we would get a Scalp PH. The problem with Scalp PH, it had a very high failure rate, and a lot of units abandoned it. So, next slide. Lactate. Lactate came up as a candidate substitute for pH, and probably a bit better. And if you're looking at the pathophysiology of this, a lactate can better assess the possibility of the metabolic part of an acidosis, and it does it a bit better than a pH measurement. And scalp lactate measurements, when they're done properly, are better correlated with base deficit at birth. And remember, we're wanting to define and identify metabolic acidosis because that tells you that the baby's has such a deficit of oxygen that the baby's having to resort to, almost desperate measures through the anaerobic pathways to cope with the hypoxia. And so once you get the baby doing that, what happens is that the baby converts the glucose into pyruvate, and then that gets converted into lactate. And this lactate hangs around for a while, and it hangs around even, after the baby's born for a while. And what it indicates in that, the last dot point says it, is that it indicates the possibility of irreversible organ damage, and clearly the organ that we're concerned about is the brain. So that's the underlying rationale for using the lactate and why it's probably more useful than a pH. So, next slide. So, performing a scalp lactate, we have to admit that it's an invasive procedure. It's a bit like having a speculum exam done, and these are universally hated examinations, but done competently, they shouldn't hurt. However, they are invasive. We clean the scalp with the appropriate materials. We make a small stab in the scalp, and for a lactate, we just need a very small amount of blood with these point of care meters. In particular, we use the stat strip machine, and you can get just almost just 1 or 2 drops of blood, and that's enough to put into one of these small machines, and far less than 5 minutes. The result, you get it in 1 minute, and the whole thing can take easily less than 5 minutes. So it's very useful in that situation, but it is invasive. Now, next slide, thanks. The reference ranges for lactate is that under 4.2 it's normal, 4.2 to 4.8 is a grey zone where you have to be looking to repeat it if the heart rate tracing remains red abnormal. And if it's greater than 4.8, the varying guidelines say that the baby needs to be born within 60 to 60 minutes. Now it's going to be needs to be birthed in 30 minutes if particularly the CTG is quite abnormal, as in, overtly red in our currently abnormal red in our current classification. If, however, there are some reassuring features on the trace, then it's probably okay to do get the birth done within 60 minutes. Now, these reference ranges are very conservative, and they tend to slightly overcall the situation, and they're based on equivalences with scalp pH and cord blood pHs. They're also based on the previous Lactate Pro device, and probably they need to be updated, but they're currently the accepted reference ranges, and unless someone publishes some rigorous work to perhaps allow us to use some broader reference ranges, then these are the ones we should use. The next slide, thanks. The original Lactate machine, I remember the one that we started using in early 2000s was the Lactate Pro that was used by athletes. That one, and that was used in the original randomized trial done in Sweden again in the 2000s. The problem with the Lactate Pro was that, in fact, it wasn't purpose-built for scalp lactate, and so there were concerns about that. There were quality control concerns, and there were a few falsely reassuring results with catastrophic outcomes that happened in various area health services, and so some places just stopped using them. So, next slide. So the Lactate Pro was abandoned by most places, but then some more purpose-built lactate machines came out, and in particular the StatStrip one, which needed a very small amount of blood, had some opportunities for quality control. So that's the,
come on.
sorry, yeah. So lactate, and then there's another machine that's being developed at present, or it's being used, the Lactate Pro TM2, again, purpose-built. So now, the reason that we started using, we were very interested in the StatStrip machine, is that particularly in this area health service, the Lactate Pro was banned from being used because it was thought to be associated with a false negative result where a baby died. Having reviewed the case, I wasn't quite convinced about it, but that's what we had to go with. And so we had a careful look at the StatStrip machine, and it seemed to do everything well. We ran it by our laboratory. We've got a rigorous quality control system, and so we're quite happy with that, right? So just moving on to the next slide. Now, the evidence around lactate, mainly, and its utility for scalp pH and as a substitute for pH, comes from Sweden. And it was an obstetrician called Nordstrom who did the original work showing that you could get a scalp lactate estimation with a very small amount of blood. It seemed to correlate well with the cord blood lactates, and there was a clear correlation with pH. So he did the basic work, and then he, in conjunction with a Swedish obstetrician called Wiberg Itzel, did a randomized trial comparing the use of lactate, scalp lactate with scalp pH in the situation in labour where you had a pathological trace or a red trace, and women were randomised to either a scalp lactate or a scalp pH. Now, the main result of that, it showed that they were both as good as one another, and there was no difference in adverse outcomes. The main difference was that you had fewer failed tests in the scalp lactate, mainly because it's a smaller amount of blood, and the point of care machine just meant that there were less complicated procedures to get the result. And really that's been replicated in various observational studies as well, that the scalp lactate is it's a much less frustrating process, because previously with scalp pH, you'd be in the tense situation where you had to say to a woman and her partner, look, we're a bit concerned that your baby might have hypoxia. We need to do a scalp pH, and then the scalp pH wouldn't work because there was some problem with an air bubble in the machine, and despite, having the machine, examined a myriad of times by either the company or the biochem lab, it kept on happening. Whereas that just doesn't happen anywhere near as frequently with scalp lactate. In fact, if you've got a well-functioning machine, it's very rare that you have machine failure or procedure failure. So the important thing is that we do have fairly rigorous evidence to say that scalp lactate is just more user-friendly, and that's a great thing in a tense situation. So now, the remaining issue from an evidence point of view, however, is that we do these lactates so that we can perhaps more confidently continue with the labour and avoid intervention. While there is some evidence from quite some time back that this is probably the case, the hard evidence for lactate is still not there. And in fact, this group in Melbourne had proposed a study called the Flamingo study. I forget what the acronym is there, but they wanted to compare pathological traces managed with lactate versus no lactate to see whether the addition of the lactate to CTG interpretation could actually reduce caesarean section and assisted vaginal births in labour. Now, I don't know where that study's up to. I think it would be difficult to conduct, but I do hope they complete that, because it will provide, again, perhaps a more solid grounding for all of this. Just the next slide. Not much on the next slide. So the evidence, as further issues regarding evidence, most of what the other stuff is from observational work where people are reporting their experiences with using these point-of-care devices. And I can say mostly it just confirms the fact that this is a more convenient test. It just needs a very small amount of blood. The machines are maintainable. And most people would say that it does help you keep a lid on the rates of interventions in relation to CTG abnormalities. Right? But again, it'll be good if further work could be done on this in a more rigorous way. Now, just the next slide. Typical clinical scenarios in which you use lactate, first of all, first stage, you might be inducing a labour. The woman, let's say 4 to 5 centimetres, she's contracting well, you start to get recurrent decelerations, you classify the CTG as red, and you stop the syntocinon and you do a lactate, and most of the time it's going to be normal. That allows you to continue. The trouble is, if you get a recurrence of the abnormal CTG, you will have to repeat the lactate. And clearly, if the labour is not progressing fairly efficiently, there's a limited number of lactates you can do. I suppose the most that we've done here in any one labour, and this is not often at all, is 5. But that's probably pushing it a bit. Most of the time we end up doing 2. Now, next slide. Thanks. The clinical scenario, the other important clinical scenario, the important one is second stage. Second stage traces, as you all know, are difficult to interpret. There are high rates of intervention because of these traces, and lactate estimations in this situation have, and they've looked specifically at second stage, have a good negative predictive value. If the lactate's normal, that baby is very unlikely to be seriously hypoxic. problem is that if the trace abnormality continues, then you need to repeat that lactate. Now, the issue is, how often should you repeat it? Well, it's going to be every 15 to 30 minutes, and you do have to keep an eye on it, because it's in the second stage that the babies can become more acidotic quite quickly. So clearly it's not just the lactate you're looking at all the other features. You know, has this woman got meconium? Is this a small baby that we're dealing with? How abnormal is the trace? So all of those have to be taken into account. Now, as I said, the hard evidence is not yet available that it actually reduces caesarean section rate. However, I just have to say, I know that in practice we have definitely prevented a few caesarean sections and forceps deliveries just by judiciously doing a lactate in the second stage where there is an abnormal trace that's classified as red, or where it's very difficult to interpret. I wish to emphasise that with an appropriately calibrated and maintained device, I have not seen a clear false negative result for any adverse outcome with the lactate machine. I have seen the lactate overcall a situation. It does have a false positive rate, but it's not an alarming rate. Can I have the next slide, thanks? At Royal Hospital for Women, we do at least 10 lactate estimations per week, and there's no doubt in my mind. So we had at handover today, we heard about one birth overnight where the registrar was quite concerned about the abnormal trace in the second stage. There was progress, and she was getting quite anxious, so she did a lactate. It was normal. That allowed an easy extra 15 to 20 minutes, during which time the woman pushed, and eventually she pushed her baby out in good condition. And that's one of the ideal uses of a lactate, is just so that we can perhaps minimise some of our interventions and get more women to have normal birth. However, making sure that we look at all features of the labour. The other thing I wish to say is that I keep a constant eye about the correlation between the cord lactates that we get and the scalp samples that we've done within 30 to 60 minutes of birth, and mostly it's a fairly pleasing correlation, as in it's good. The only thing I'd say is that sometimes, probably, let's say 5 to 10% of times, the lactate overcalls it a bit, all right? But that's far better than having a false negative. So, and I haven't seen a bona fide false negative. False positives do exist, and current reference ranges we use are conservative. We're embarking on a project where we want to compare the cord lactates with the stat strip, with the scalp lactates, just to see whether perhaps we can adjust our reference ranges safely, so that we don't get perhaps too many false positives. Now, next slide, thanks. Now, the future, however, for this type of thing is that it'd be good if we could have, even perhaps slicker packages to get the blood, etc. And there are a few publications where a number of inventive, innovative types are proposing an all-in-one package to be able to do the lactate estimation in a more efficient way, and I think that's a good thing.
The lactate sensor.
So then lactate sensors are also being proposed, where you have a lactate sensor is put on the skin, and you get a continuous estimation of lactate. Now, I think that will be very interesting, but that's still in a very experimental stage, and it's been used in various animal models. The other important aspect of the future is that as we better understand the oxygenation physiology and pathophysiology in the second stage of labour, I think we'll be able to develop, better tests, lactate included, to help us in the management of labour. So, next slide. So that's really most of what I had to say, and I just emphasise that scalp lactate estimations with our current point of care devices, and mostly that's a stat strip, is invasive. However, it does have useful test characteristics, and overall, practically, I'd have to say it's useful. All right, mainly because it's allowed some women to avoid intervention or have a more straightforward intervention. It does help keep a lid on caesarean section rates in a reasonably informed way. I think we need a better definition of reference ranges. However, we need to stick with the current reference ranges. And I think we should await results of further observational studies and randomised controlled trials, just so that we get a more precise idea of its effectiveness and use. Okay, that's me done. Any questions?
So if you want to open the lines, if you want to ask Andrew a question, you just need to take your phone off mute. So anyone? Questions for Andrew?
How long is a normal lactate reassuring for in labour?
Okay, look, it's going to vary depending on how bad you think the CTG is. If the CTG remains, in our current classification, a very clear abnormal red, then I think you have to repeat it probably within 20 minutes. If, however, say the CTG recovers to yellow or normal, then, sometimes you don't have to repeat the lactate, or you might be able, you would just repeat it in, say, an hour. Where you have to be cautious is when you're in that very active second stage. That's where acidosis can, develop fairly quickly. So that's where probably you're having to repeat the lactate in 15 to 20 minutes. Yeah.
Hi, Andrew. Can I ask a question? Can you hear me?
Yes, I can. Yeah.
So if you've done a lactate during second stage or during labour and it's been okay, but, we do our cord PHs, after birth, and you get a lactate of, say, 6 and above, do you routinely repeat the lactate in 4 hours after birth?
If you get a very high lactate on the cord lactate?
Yes.
Leave that to the neonatologist, but yes, we do, yeah.
We do, and I'm just wondering if you do it, are you able to use the machine that you used for
No. I'd like to, but no, they use their own technology, yeah.
Okay then, thank you.
Yeah, no worries.
So are there any more questions for Andrew before we finish up?
Andrew, I'd like to ask, we're in a rural LHD, and is this a midwifery procedure or a medical procedure?
Look, it's traditionally been a medical procedure. However, given the ease, it's a very straightforward technological setup. I think it's clearly learnable by midwives. Right? It's just that there would have to be a very clear understanding with medical staff, and then issues of training. But yes, I would say yes, it is. Yes.
Thank you.
Okay. Are there any other questions of Andrew at this stage? Because we're due for our 3 o'clock session in a minute, so Andrew may want to take a break. So last questions for Andrew at this stage.
Do you think that this could be a useful thing in a rural setting where we have limited facilities and we have the need to transfer out when CTGs do look bad?
Yes, look, I've always thought that a lactate estimation, properly set up and just making sure the machine's calibrated and everything, could actually serve rural areas quite well.
Thank you. Thank you.
Yeah.